So welcome to session 4. It's our last session for Impact already, which feels unbelievable to me. But welcome. Today we have a great session lined up about understanding barriers related to clinical trials faced by newcomers to Canada, a roadmap to understanding clinical trial needs in your community. There was a lot of great questions and discussion about that this morning, so I'm looking forward to kind of continuing that with this session. We are delighted to have Munaza Jamil and Alison Orth here with us today. Munaza has over 22 years of experience in the world of clinical trials. She leads the monitoring program at MyCERN. She's on faculty at McMaster University, where she teaches in the Applied Clinical Research Program. She also chairs the N2 Public Engagement Committee, where she champions many different EDI initiatives. Alison is a health research leader with over 25 years of experience in leading multidisciplinary teams and organizations in both the private and public sectors. She is currently the portfolio director of research programs at Michael Smith Health Research, BC. So thank you very much. Over to you.
Thank you so much, and good afternoon, everybody. So, fourfold learning objectives today. We wanted to increase awareness of the diverse landscape in Canada, and then investigate how we can leverage this to encourage diverse participation in clinical trials. And we wanted to do this by sharing some learnings and insights that we had from a recent community consultation with new immigrants to Canada. This was a CIHR-funded initiative. We also want to share some learnings from a pediatric parent survey focused on improving enrollment into clinical trials as well as the patient experience, and then determine actionable steps that study teams can take to enhance diverse patient involvement in their research projects. Right? Gratefully acknowledge that we are gathered today in the city of Vancouver, situated on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. So, of course, we already know this. This is just sort of a framing slide. We know what the importance of diversity is. We want to make sure that the research is representative of the population that it wishes to serve, and people experience the same disease differently. So the more diverse a group of clinical trial participants, the more we can learn about the safety and efficacy profile of a potential intervention, medicine, vaccine, etc. Equity in clinical trials means that the participants represent the people who are most likely to have the health condition and need the treatment that the trial is investigating. We know that clinical trials have often lacked diverse representation, and despite Canada's diverse demographic, many studies still disproportionately overrepresent Caucasians. So it's really important to address this disparity, because we know diversity is essential for ensuring the broader applicability of our research findings. It is improving, but addressing disparities for some equity-deserving groups, such as the new immigrant population, is necessary to consider. And when I say new immigrants, I also want to include asylum seekers and refugees in that term. So just to give you some background on why this particular population is important. So just over 1.3 million new immigrants have settled in Canada in the last 8 years, which is the highest number of recent immigrants recorded in a Canadian census. Nearly 1 in 4 people in the last census counted themselves as a landed immigrant or a permanent resident, which is the highest proportion since Confederation and the largest proportion amongst all G7 countries. And by 2041, 34% of the population of Canada will have been born outside of Canada. So with its high percentage of foreign-born citizens, the Canadian landscape presents really a golden opportunity for researchers to drive their projects to success by enhancing diversity in the participation, but also by fostering a diverse clinical research workforce. And this is important not just to increase the overall quality of the trials that are conducted here, but also to provide equitable access to clinical trials. So our project was CIHR funded. This was last year. It was called Breaking Barriers, Promoting Diversity in Clinical Trials for Newcomers to Canada. And this was through the work of the N2 Public Engagement Committee, which I chair, that we received the CIHR funding for a Café Scientifique program. And so we decided to do a public consultation, a public workshop with new immigrants. Fourfold objective of the cafe, we wanted to increase an awareness and understanding of clinical trials within this population. We also wanted to have an increased understanding of the barriers that this population faces when accessing and participating in clinical trials. We want the clinical trial community to develop effective materials to engage this population with research, and then also to create a model, hopefully, for future workshops and future community conversations that can happen, not just with the new immigrant population, but with any population in the local context that you wish to consult with. An overall summary of our learning. So we categorized all of our insights and learnings and findings into 6 buckets, and this is what they are. And I will just talk about them one by one briefly. All right, so accessibility. So when you're a new immigrant to Canada, firstly, it is very, very difficult for you to even find a family doctor or a pediatrician or a primary care provider. So that in itself is a huge challenge. Research is after that, right? So the first thing is for you to be able to find somebody. Navigating the healthcare system, new immigrants will report, can be quite challenging and quite harrowing. A lot of individuals, if they fall into the refugee or asylum seeker type of category, may not even have proper healthcare coverage, which makes them often ineligible to participate in a clinical trial in some cases. What we learned with our conversations with this group that evening was that they don't necessarily trust online information that is shared through a website, and they really, really prefer face-to-face, in-person interactions when learning about research, when learning about research projects, trials, studies, etc. So, one of the things is the Public Engagement Committee at N2 has a website called itstartswithme.ca. And this is a website that is public facing, and it's just about, people can come over there and learn more about what clinical trials are and how do I get involved and what does it mean, and frequently answered questions and things like that. So when we were planning and preparing for this workshop, we thought we would take this website and show this to, the attendees at the consultation and ask them what they thought about it. Did it answer their questions? Were there things that resonated with them, or were there things that they wanted to add additionally? And so when we're there and we started to talk about it, we just found that nobody was really interested in going onto this website and reading anything. They were actually just interested in having the discussions that we were already having with them. So just to maybe step back a little bit and give you the format in which we did the evening. So we had a couple of very brief presentations at the outset, and this was just about intro to research. And there was another presentation by a caregiver with lived experience where they were taking care of a clinical trial participant and their journey and what kinds of barriers and challenges they face and what kinds of questions they asked and all of that. And then after that, we divided the entire room into smaller groups, and we had facilitators from our team sit at each table, and we had maybe a list of 7 or 8 questions that we wanted to talk to the audience with. And these were all around their experiences and what their perspectives were about research and trials in general, and then what kinds of barriers and challenges they were facing when they were approaching research or accessing research or participating in a clinical trial. And many attendees also stated a preference to have sessions in a group format. So they really liked what we were doing, and they were asking when we were coming back and if we could do like a monthly type of evening with them at the community center where we were, and just tell them about anything to do with research or medicine or anything like that. And so group settings were preferred. Group settings in their trusted environment. So they wanted us to come to them, which I think we've heard about as well. And they really, really appreciated that we came in. Like I said, they were asking, when are we going to come next? Okay, the second piece was around trust. So A lot of individuals, of course, will have different types of experiences in their home countries around medicine and healthcare and illness and research, et cetera. And there is a lot of misconceptions and mistrust around it that we need to, I think, overcome through conversations like these. So one of the really like prominent sort of, learnings that came out was that there's this sentiment where because someone is a new immigrant, or they're new to the country, they're going to be treated as an experiment basically, and that randomization is not actually truly random, and that they will be assigned to a placebo group perhaps because they are not worthy of being in the intervention group, or so. So these of course stem from historical experiences that individuals have had and knowledge that they bring with them. And so it's really, really important to understand A, where they're coming from, and then B, what can we do to address these types of varying perspectives and overcome them. The other piece is that we know that healthcare is privatized in many countries around the world, and people have to pay to access basic healthcare and health services. So there's a real concern where, they said a scientist or a researcher might be wanting you to enroll into a trial because they're going to be paid to do the study. So the more patients they enroll, the more they get paid. Now, we know that, researchers and PI sometimes do get stipends, but we also know that there are so many steps in place that make sure that that can't be violated, and then, someone can't just do whatever they want. But there is that very, very real concern. Sharing personal information as well, depending on what their status is in Canada. And this at the outset, we noticed because when we had our flyer go out in the community center and in the neighborhoods that were adjacent to the community center, we in hindsight now feel like we didn't do a good job with the promotional flyer because we weren't very clear. And I think there was a lot of confusion around, are we actually conducting a study at the community center that evening? And so there were a lot of questions around, well, I don't have my health card. Are you going to be taking blood? What is this for? And then the other piece was we had in our budget some gift cards to give to the attendees as a thank you. And because for accounting and auditing purposes, we needed to collect their information, just very basic information that they needed to give us when we would give them the gift card so that we would have a track record of that. And there was a lot of hesitancy around sharing that information because people simply just didn't want to give us that information. And they didn't know whether, there were actual questions about, are you going to report me to the government? Are you going to deport me? And so very, very real and serious questions and worries that these people have. So that just goes to show how much of a gap there is, right, in the understanding. Cultural competence. So we know that there is a need for researchers to understand the cultural and contextual sensitivities, including religious factors, that this was also brought up in our conversations. And like I said before, immigrants often do undergo a lot of traumatic experiences in their home countries, in their journeys with migration or immigration to Canada. And that does impact how they view medical research and the medical research community. And that's how, their perceptions are shaped. So we would need to address that. Communication. So one of the bigger sort of conversations was around how a lot of cultures have family units that are really, really strong, and they function as a unit. So they function together in terms of counseling, advice, guidance, support. It's a circle. And when they said that when they come here and they go into a doctor's office and somebody approaches them to participate in research, it's the model is sort of like, well, you're autonomous, so we need to get your consent. What's your decision? And they don't necessarily feel like their circle, with their family is necessarily accommodated. And so they said, we really do look to our family members sometimes for advice and support. And this is not just initially at the consent, stage as well. This is an ongoing piece. So importance of involving caregivers and family members in discussions, and then also also maybe even allowing caregivers to be translators and interpreters, because oftentimes people do struggle. Of course, we know that there's limited resources with interpretation at healthcare institutions, but if we were to genuinely accommodate, be a little bit creative and accommodate caregivers with the consent of the participant and allow them to interpret or to translate, we could maybe end up enrolling, a few extra patients who are maybe not English speaking, and we typically exclude them right off the bat because they don't speak English. Also the importance of seeing people like you. So represented in study teams, so in the workforce as well, and as well as in printed materials, etc. And they also highlighted the presentation on that evening with the caregiver with lived experience, because they were also an immigrant, and they had, they felt that it does reduce some hesitancy when you hear from peers. So transparency is different from trust. The earlier slide was about trust. That was more about making the decision to participate in research. Transparency was more about, you've made the decision and now you're enrolled in the trial, but there's concerns about how transparent are the study teams going to be with me, or the scientists going to be with me. And this was a recurring theme about perceived risks with experimental clinical interventions, and then the idea that they are not going to receive, just and fair sort of access to the trial. And also that if they experienced adverse events, that maybe the researcher or the PI wouldn't withdraw them or wouldn't make proper decisions for their care, because once again, in their mind, they're being motivated by financial gain. So why would they take you off this medicine if they're going to, be motivated by financial incentives? I'll give you an example. I just want to pause here for a second and just to share an anecdote with you, because I think that this really demonstrates how big this gap is. So I come from a small country in Southeast Asia, and I went back a couple of years ago, and my cousin, my uncle's daughter, had received her immigration papers to come to Canada, and she's a nurse. So she was really excited about moving to Canada and working as a nurse and all of that. And my uncle was really not very happy. So I asked him, why aren't you excited? Like, she gets to go and she gets to start her career, and she's young, and her passion is nursing. And he said, well, the thing is that I'm afraid that when she gets there and she starts work, they're going to assign her to the infectious diseases ward. And I said, why would they do that? And he said, well, because she's new and she's not white and that she's not Canadian. So maybe they'll put her there because she's just some lesser form of humanity and is disposable. So if she gets an infectious disease, it's okay, type of thing. And he's pretty educated, and this is like, in this day and age, but these are the very real worries and anxieties that individuals hold to this day. So imagine how much work we need to do in this area, right? So language, clinical trials, materials, we know that oftentimes they're just translated in French and English. Oftentimes questionnaires and instruments are validated only in English and French. And we do know also that there are many, many more languages that are spoken here. Fun fact, 200 mother tongues reported in the 2016 census in Canada. And this is, once again, it kind of connects with the piece about having a diverse workforce. So when you have individuals that represent different races, ethnicities, languages, etc., on your staff, they can become a resource for you to speak to participants or to have those conversations in a culturally appropriate and sensitive manner. And then also, of course, using language, the language that we use in our materials, we really want to be very sensitive about that because they have different connotations in different people's, languages, cultures, contexts, etc. And with that, I will give it over to Allison.
Thank you, Manaza. Inspiring as always. This is a two-part presentation. We're talking about the same project. And what I wanted to do when we undertook this Café Scientifique consultation, It also became clear that some of the things we were thinking about in the planning and some of the findings that we heard were similar to other surveys we'd done in a broader Canadian population. And so through work at Clinical Trials BC, Clinical Trials Ontario, N2 and other community partners, there's 2 surveys that we've done in Canada, one being a participation experience survey. Some of you in this room were part of helping to enroll for this. And this is Canadians who were approached to participate to be in a clinical trial. So at the community awareness, it was, what do you think about clinical trials? What would you think about if you were asked to participate? In this case, these are Canadians that were asked to participate, and they either declined or enrolled. We had 1,000 responses. Of those, 90% of the responders were white, and 10% were in the pediatric population. The parents had responded. We also did a public opinion survey around the Canadians' awareness and perceptions of the benefits, risks of clinical trials, and where they would want to receive information about clinical trials. And that was 1,600 residents from BC and Ontario. We thought it would be interesting to look at what was similar in some of those findings or themes, and where were the key differences. So between those 2 groups, there was in both groups low trust in the internet information and social media, a lot of concern with blood sampling in terms of the number of blood samples and the amount of blood samples that would be collected in the research. Of course, worried about the side effects. And for those that were hoping to improve their health, not the healthy volunteers, but potentially seeking a new treatment, did not want to be in a placebo group. Everybody wanted to have more general information about the process of clinical trials. How are they run in Canada? What is the ethical oversight? Do the researchers get paid for doing this, and how does that work? And they all expressed a need for transparency and reporting during the trial, communicating with the participants, and after the trial around study results with community and individual participants. What was different was around the source of information about a specific trial. So mostly Canadians would like to hear about trials from their physician or their primary care provider. But in the newcomer population, they wanted to receive information from their community in a group setting with others or with their family, and from trusted sources that they regularly engage with, but not healthcare providers. Canadians generally aren't concerned about their privacy risks when they participate in clinical trials, but the newcomer group was very concerned and actually suspicious, as you heard from Minaz, about sharing personal information. And Canadians have a lower concern with financial motivation of researchers when they're doing clinical trials. We have a public healthcare system. I think they are aware of how a lot of this, how the clinical trials basically are being run within the care system. And the newcomer population felt there may be hidden agendas and financial motivations of doctors and also the companies and other research entities. I'm going to talk a little bit about recommendations. So after we held the event, the N2 Public Engagement Committee, we got together, and those that were involved, and talked about what is it that we could actually do to address or recommend that would help to address some of the concerns. And those really fell into 3 areas. So education and awareness, facilitating access to information about clinical trials, cultural competency training and mentoring, and developing a diverse clinical trials workforce. Around knowledge and engagement, so Manasa touched on some of these when she told you about the learnings and what some of those specific concerns are. And I'm just going to run through some of the ideas that we had or recommendations that we have that we think you may want to take back into your own practice. Establishing or working with a community advisory board would be very helpful. And perhaps there already is a community group in the community of the population where you're going to be working that you could partner with. Conducting community engagement activities similar to the Café Scientifique with in-person interactions that are over time, they can start to build trust with the research institute, the people associated with that, or the healthcare system where research is being done. providing information sessions about clinical research broadly, but also you can do this about specific pieces of research or trials. And then providing opportunities to members of the community to actually be ambassadors of your project. So we talk a lot about patient partners, and this can be in a similar approach, but some ways more that's your community folks that are supportive of what you're trying to do and are willing to talk about you and the research with the members of their community, or be there when you're holding the events and help you invite people into the events and into conversation. Some of the other ways that you can increase the general awareness and engagement from newcomer population would be to provide testimonies from former research participants that they identify with. Also from local physicians and practitioners who are trusted. There may be public health nurses, there may be other care providers or physicians that are working deep in community that they may trust. If you can find them and you can have them somehow either part of your research team or connected to your research and able to speak to it. And then communicating with the family and the caregivers of the person that would be eligible to enroll. With permission from participants, if you can involve them and that's what the participant wants to do, as much as possible, it's helpful. And we talk about dissemination plans. I know it's a requirement from in the Tri-Council policy that you disseminate, share back the research findings. It says with community. It doesn't actually say with individual participants, but I know that's also very important. And we hear it's not often being done. So to maintain trust and transparency, it is really important that you regularly communicate what's happening with the research along the way and at the end of the study with what the results were and what the next steps are with community and with the participants. Some other ideas that we came up with, again, we know lay language in research materials, but it's even more important in this population, avoiding stigmatizing language and having an understanding of those cultural sensitivities. Again, somebody from community to help you with this, a patient partner from community is going to be really helpful. And making sure that the community can see themselves in these materials, in the language that's being used, and the images that are there being represented. What are some other ways that you can facilitate access to information about research or the specific clinical trials? Manaza touched on this around translation and including finding ways in your protocol and in your process to allow caregivers to be conducting that translation services. We heard about going out to the community instead of them coming to you. So can you look at some of the methods in decentralized clinical trials and apply them for your community engagement? Use technology where possible to do that. Similar to all Canadians that we hear from around clinical trials, the barriers to participating are often logistical ones. The hours that the clinic is held is not conducive. They're at work at those times. The study labs, or they're not available to do that in the evenings or the weekends. Or they have daycare needs, or they need to travel to and from the site and don't have transportation. It's not easy for them to get there. So making sure you think about those things and try to have some flexibility, go out to community when you can, and find ways to make it more easier for them to come into you. Cultural sensitivity or humility training is an absolute must for research teams before they interact with community patients and family members. Understanding your cultural competence understanding is not only vital for successful and culturally safe community engagement, but also in your research design, your implementation, your recruitment practices. It's very important. Often, and we hear this too generally, about when the trials are being designed, they're being designed for the scientific purposes, making sure that your sample size is going to be big enough, making sure you're going to have validity, making sure you're answering the research questions. But in the design, also very important to build in the perspective of the participants, the clinicians who will be supporting on the research team, and the communities. And finally, having your research team be more reflective of the communities you're engaging with can be really helpful to building trust and rapport. Addressing the barriers and facilitators to participation that we mentioned, and developing and implementing strategies that are tailored to the needs and preferences of these populations. Again, this is all to ensure that the research questions, outcomes, and measures are relevant and meaningful to the populations you are studying. To close, our call to action from the group is that more education and awareness is needed about why inclusion of underrepresented groups are critical, that training in cultural competency is needed for the clinical trials community broadly. And we need to advocate for an infrastructure to be in place so that future conversations and engagements can continue. So that could be local infrastructure, that could be at a provincial level or national level. We want to thank the support of N2, of CIHR for the funding, and our colleagues who were involved. And there is a white paper that was published that you can find this information in on the N2 website, which is n2canada.ca. And we thank you very much. And I think we have some time for questions.
Thank you for a lovely set of talks and panel. I have a practical question, mostly for Munaza, but maybe it's for both of you. In regulated clinical trials, what is Health Canada's position with using unofficial, non-validated? So a lot of the translation we're talking about falls into the non-validated translation category, right? Are there discussions happening at Health Canada, or are you aware of what is the current positioning for allowing non-validated translations to facilitate inclusion?
Yeah. So two things. Firstly, I know that there is now more push from the sites to industry sponsors to provide either funding, additional funding, for validation of instruments and questionnaires, et cetera, that they are using in their study based on the languages that are most commonly sort of seen in that site's, catchment area, et cetera. Also some additional funding for translators and interpreters. I don't know necessarily exactly what Health Canada's position is. It's sometimes extremely difficult to understand what they're thinking. But I do know that this is now on the radar. So we did have a meeting with CIHR a month ago or so to kind of loop back with the findings from this cafe. And I think they found it very valuable. Firstly, I don't think many people come back to them and talk about the results of their cafes. So they were very excited to hear from us, but also I think acknowledging the need for more work to be done to practically implement these types of things. And that's what I was talking about, where, you could potentially think about sometimes accommodating caregivers as interpreters or translators. Caregivers can be a huge resource if we weren't just to exclude them off the bat, within the proper context, they can be. So I think at least in that meeting, I felt like there was some acknowledgement that there needs to be more conversations and things. And I do know from at least 2 pharma companies that I've spoken to is that they've been receiving a lot of pressure from sites and pushback on the budgets to say that we do need interpretation services, et cetera, and so that we can accommodate more patients.
So to your point about the unvalidated scales, we went back and forth with some of our epidemiology colleagues at McMaster. And the thought, the thought is from the pundits, is that you should use the unvalidated measure at the expense of the data integrity, which means essentially optimizing external generalizability, knowing that your validity may suffer. Because the number of patients that you would use an unvalidated scale is probably very small, and maybe you can adjust for your sensitivity analysis, whatever, blah, blah, blah. So that is kind of what we are doing. The other issue is that TCPS2, the nice thing about this is great work, by the way, Manaza, And TCPS2 does provide a framework for how to respectfully, meaningfully engage communities, not just Indigenous communities, but other communities as well. And this is really important for things like diabetes, hematology, many other medical conditions. The issue is a logistic one. So most centers have translation services available through video conference. So even if you don't have a person there that can translate, the video conference allows you to do that. And in high throughput settings, such as clinics, ambulatory care settings, we really rely on those things. The downside is that they cannot help you because Health Canada requirements, and which filters down to the REB and the local RI oversight committees, says that that translator has to sign a document attesting that they are translating. And that signature has to be attributable to that individual. And the person online can't do that. So that's the logistic issue that I think a lot of investigators face, because yes, they want to include people, of different backgrounds, but if English isn't, or French isn't their first language, it makes it challenging.
Yeah. Yeah.
So actually, thank you for that, because we made the same decision. How all this translation worsens signal to noise. There is very little empirical data to say that when we use multiple languages without official translations, we decrease precision of measurement, right? Yeah. So it's an impression we all have, but if you actually look, where is the empirical evidence for that? There is very little. So we've made that decision for pretty much everything we do except regulated trials. So for the regulated trials, where we're a bit stuck is not whether we're gonna get noise, it's whether we actually gonna have an auditor, or whether we're compromising an indication by an auditor saying that the specific piece of data acquired through a non-validated translation cannot be used for the final assessment of effect size. So this is where I'm a little stuck. And that's why I was asking Munaza if Health Canada is having the conversations, because, and if anybody else knows, like, would it survive an audit, a Health Canada audit or an FDA audit?
Do they know about that? Like I was just thinking about, Jennifer Clayton's language barriers project at BC Children's. So I wonder if she's had any experience with how to, because she did email me once to ask me about the instrument validity. So I wonder if their group might have some more, and I'll check with them and hopefully find some more information from you. For you.
Thank you. That was a great presentation. I'm Maureen Smith. I'm a patient partner, and I have a question about recruiting diverse populations to clinical trials. So one of the things that we know, I think by now that works, is for researchers to work with patient partners who come from those communities, who understand their needs, who people can relate to, and you alluded to that, and you seem to have CIHR's ear. So I'm going to ask you a question. So try to do that in getting together a grant for some projects that I've been involved with. And when we get to the grant application stage and they have to go through the process, if they want to be like a co-investigator, we want to give them as much, like we want them to be part of the project as true partners. And they get to either the applicant profile CV, or they get, and they have to do the significant contributions. The significant contributions instructions are written at a grade 15.9 reading level. And the questions that they ask, things like what are honors and things like, they're devaluing people. So now we're talking about EDI, and we've got CIHR promoting it all the time, yet they're like 10 years behind in those applications. So researchers either have to go one-on-one with those people and basically say, oh, we're not trying to devalue you, like you're very important to us, and convince them that those questions really are not the ones that they have to answer, and work with them to fill out those forms. It's terrible. It's a terrible way to do it. So you said that you've been talking to CIHR, and is there any movement on that at all? Because I've personally had conversations with them about it, and I'm not getting anywhere. They're saying, can you guys maybe keep up with the times and change the questions and make them relevant to what you're looking for in those people, and fix it up so that you're not at a grade 15.9 reading level just to read the instructions, never mind the questions. So hopefully you can encourage me.
I totally see your point, and I know I'm very well aware of this discussion and this conversation that's happening. I know that they are aware of it, but like you said, I don't know if they're quite ready to address it just yet. There's many things. One of the things that we talked about in that meeting as well was about how CIHR applications and grant applications always have this this mandate around diversity and enrollment and all of that. But firstly, there's no accountability, right? So nobody ever asks you at the end, like, what did you do? And if there is, then it's very easy it's just tokenism, right? Like it's very easy to fill up those sentences. This is what we did and this is what we have, and that's just the way it is. So one thing that I was talking to them about was this gap, firstly. And then the second thing is that we oftentimes talk about research teams, approaching and approaching communities and having conversations with communities, individuals, et cetera. But really, how many people feel like they have very strong training in culturally appropriate communication, cultural sensitivity, cultural competence? And many people feel like when we talk about cultural competence, that it means that you need to be aware and knowledgeable about every single culture that's out there. And of course, that's not the concept at all. I mean, the idea is that you have the skill that is needed to approach conversations with curiosity, with humility, and with respect. And that way you can have conversations with just about anybody if you have that skill. And so one of the things that, they did say as well is that there is a lack of a standardized training nationally for researchers on cultural competence, cultural sensitivity, humility, et cetera, and all of those things. So I'm hoping that, they were actually saying, maybe N2 can fill this gap and so we'll definitely going to take these conversations forward. And so stay tuned on that, but that, many gaps for sure. Absolutely agreed.